Good morning and welcome to the Philips Sponsored Symposium. My name is Marko Ivančević and I'm the Director of Key Customer Relations for CT in North America. Our speaker today is Professor Tim Leiner. He is the Chair of Cardiovascular Imaging at the Department of Radiology and Nuclear Medicine of the Utrecht University Medical Center. Today, Dr. Leiner will speak about the next generation Spectral CT for cardiovascular applications, featuring our newly released Spectral CT 7500 system. Welcome, Dr. Leiner.
Good morning. My name is Tim Leiner. I'm a radiologist at Utrecht University Medical Center, and I would like to thank you for the opportunity to share with you our initial experience with next generation Spectral CT for cardiovascular applications. So in this lecture, I'll walk you through what is unique about Spectral CT. We'll talk about the new features of the CT 7500. I'll show you clinical examples, and I'll finish the talk with some considerations about Spectral CT and radiation dose. So let's start with the basic principles of dual energy CT, which is what we mean when we talk about dual energy CT. We refer actually to dual spectrum CT, with the ability to create different contrasts in addition to conventional Hounsfield unit-based images after the acquisition. As you know, there are different solutions supplied by the different vendors. So there's a dual source option, which uses dual X-ray sources to obtain two different spectra. There are systems with rapid kV switching, which change the kilovoltage during the rotation very quickly. There's the opportunity to do dual spin acquisitions, which means you rotate twice with different energies. That is probably the least attractive option if we're imaging the heart or other fast-moving organs. And the subject of this talk is dual layer detector approach, which is the Philips approach. And the nice thing about this platform is that this information is always on and always available in every patient. So once we've acquired dual energy raw data, we can reconstruct images, and these can take the shape of conventional images, which are Hounsfield unit based, such as virtual non-contrast, the conventional CT images we're used to, but we can also create virtual monoenergetic images as if they were acquired at a single X-ray energy. These are all Hounsfield unit based images, but there's also the opportunity to recreate material density images, for instance, which can quantify, for example, the concentration of iodine in different tissues and body compartments. We can also display the effective atomic number for each voxel, which is called effective Z. And there are other options, but these are some of the more commonly used options that dual energy offers you. So why did we choose the CT 7500 at Utrecht University Medical Center? Well, first of all, because it's always on spectral, this system. So in every patient, the images that are obtained contain dual energy information. There's no need to think about whether or not you want to turn this feature on or off. So everybody who comes off the table has dual energy information encoded into the images, which can be used when you need it, in expected situations, but also for unexpected findings, which is a particularly powerful tool for reducing the uncertainty with regard to unexpected findings. So another big advantage is the ability to low radiation dose, because we can often obviate non-contrast scans, because we can create virtual non-contrast scans out of the contrast enhanced images. And we can also lower radiation dose, but more about that later. We can also obtain scans with less contrast material, so lower contrast medium dose. And that is because when we create virtual mono-E images at low monoenergetic levels, the iodine contrast is boosted, which means we can inject less contrast, but still get images as if they were obtained with more contrast. So this is also a very powerful feature that will save money and is good for patients. And finally, in the 7500, there are advanced cardiovascular imaging features. Obviously, the 8 centimeter coverage is very important to get quick images of the heart and 2 heartbeats or less. There's fast table movement, which is very advantageous when imaging, for instance, entire aortas for TAVI workup or trauma. And there's advanced motion correction, which I'll show examples of later in the presentation. First, a little bit about contrast attenuation at conventional CT versus spectral detector CT. So what you see here on the x-axis on the left side is the effect of going from 120 kVp to 80 kVp. And what you see when you look at the y-axis, this is the attenuation, that the attenuation goes up when we move to a lower kVp. And that's entirely expected. And the attenuation depends, of course, on the concentration of contrast agent, which is represented by the different colors. So what you need to notice, however, is that this effect is much greater when creating monoenergetic images out of dual energy CT information. So with the spectral detector scanner, the 7500, as well as the Icon, you can create very low noise, high contrast to noise images that go all the way down to 40 kilo electron volts, which tremendously boosts the iodine density, as you can see from this graph. And this was published in 2018 in the Journal of the International Journal of Cardiovascular Imaging. So this is the attenuation. But if you look at the dose-corrected contrast to noise, this effect is even much greater. So there's not as much effect from lowering the peak kilovoltage, but the attenuation or the contrast to noise ratio goes up tremendously if you create these virtual mono-E's. So this is a very powerful strategy for reducing the amount of contrast agent that is injected, thus again saving costs and exposing patients to lower amounts of iodine. So let's look at the new features of the CT7500. So we have an 8 centimeter dual layer spectral detector, and this is opposed to the 4 centimeter detector in the Icon. So this is a 512 slice machine instead of a 256. There's better patient access and comfort with the 80 centimeter bore, and the table has a 2 meter scan range with a much higher table speed. So the table speed is now 60 centimeters per second, which enables very fast imaging of the entire body. The table is also suited for bariatric patients up to 306 kilograms or 675 pounds. There's a power scan mode, which also is good for bariatric imaging at 120 kilowatts. And in the very near future, the system will also be capable of scanning at 100 kV for spectral applications. Finally, there are smart algorithms and analytics built into the system, as well as the system runs on the iPatient platform, which is a very easy to use platform for technologists when they plan scans. So this is our CT7500, and we started using this system in early April. So our experience is right now of a couple of months. So I'm going to show you some cases where I found that the system was very useful to have and to use the dual energy information. So these are some clinical examples. And CT of the coronary arteries is obviously one of the most attractive applications for this new system. So here's an example of a coronary CT obtained on the spectral scanner. And you can see the beautiful image quality, high contrast to noise because of the iterative reconstruction with IMR, and very nice delineation of the cardiac structures, including the coronary arteries. But as you all know, the coronary arteries are often calcified, and this can represent a problem in terms of assessing whether or not there is a stenosis. And this is where spectral information can help you. So we know that the high calcium burden limits the diagnostic accuracy. And this is an example from the IntelliSpace portal where we reconstructed an iodine no water reconstruction. And this reconstruction greatly reduces the blooming artifacts by the calcium, as you can see in the lower part right here. And you can actually judge the lumen quite nicely in this MPR reconstruction. And you can actually see that there's a significant stenosis right here at the origin of the vessel and all the way to the right here, further down in the LAD, and that the heavily calcified parts are in fact not significantly stenosed. So this is very useful to actually pinpoint the exact area of the problems in coronary arteries that are heavily calcified. Well, another advantage of spectral CT is, of course, the capability of making iodine density maps. And to show you the power of this tool, I'm going to show you this case, which is the same patient as in the previous slide with a heavily calcified coronaries. So what I did here on the left side is I made a map of the Hounsfield unit densities of the different sectors of the myocardium. And you can see that there's some variation, but only when we create an iodine density map, we can unmask with great certainty this perfusion defect in the septum. So we can actually measure the iodine concentrations, and we can see that in the septum here, there's a 0.2 milligram per milliliter concentration versus almost 10 times as high in the lateral wall. So using the spectral information is really helpful in getting certainty about significance of stenosis and perfusion defects. So this is a very powerful tool in our opinion. So this patient went on to the cath lab and turned out to have a significant stenosis as measured with invasive FFR, the value of which was 0.72. So yeah, the spectral information really helped to assess the presence of a flow-limiting lesion here. Okay, so I told you that one of the new features in the system is an advanced motion correction reconstruction, and I'm going to show you a couple of examples in the coming slides. So this is an example using step and shoot. And when we focus our attention on the right coronary artery, which is often the artery that moves the most, take a look at these differences in delineation versus on the left side, you see the motion corrected reconstruction. On the right side, you can see the conventional reconstruction. And when we zoom in on the middle part of the right coronary artery, you can actually nicely see this effect again. So here the vessel is really nicely, sharply delineated, whereas on this conventional reconstruction, you can still see motion blurring. Here's another example. Also focus your attention on the right coronary artery again. So there's some motion artifacts in the conventional reconstruction, whereas on the motion corrected reconstruction, these artifacts are almost entirely gone. And again, zooming in on this area, you can see this very nicely. And obviously, this is of great advantage when you want to measure, for instance, the plaque burden in coronary arteries. And there isn't that much plaque. So in the earlier stages of atherosclerosis, you can imagine that when we have these non-motion corrected scans, that there are still artifacts with regard to assessment of plaque, as well as errors, of course. Now, this scan method works as follows. So it works by first detecting tubular objects, i.e. the coronary arteries, over a region of interest around the targeted cardiac phase, which is diastole most often, of course. Following this, elastic registration is performed over the region of interest in the generation of the vector model representing the displacement of these tubular structures around the phase of interest. And the knowledge provided by this vector model is then used as part of the back projection, resulting in the reconstruction of a motion-corrected image, which you can see on the bottom right here. Now, this also, of course, works with retrospective scanning, which I'm showing an example of right here. So on the left side, again, we have the motion-corrected reconstruction. On the right side, the conventional reconstruction. And notice how nicely the early plaque development is depicted in this patient. And again, if we zoom in on the details, especially again on the right coronary artery, we can see that there's a big reduction in blurring due to motion. So the principle is the same for the helical acquisition, but of course you have more width in terms of the cardiac phases that you can assess in order to assess motion of the coronary artery and correct for this motion. All right, well, one of the big advantages, as I said earlier, of spectral CT is the ability to generate a better contrast for soft tissues. This is not only interesting for the coronary arteries and the myocardium in the context of perfusion, but also in the context of delayed enhancement. So on the left side here, we have a patient with a 41-year-old male with a ventricular tachycardia. Patient has an ICD, as you can see. And the question here was, is there any delayed enhancement? And if so, where is it located? And so what we do is we acquire a conventional CTA. At 6 minutes, we do a late enhancement scan, of which you can see the conventional reconstruction right here. So this image has very poor contrast between the different compartments of the heart and the myocardium. So let's see if we can extract additional information by using spectral reconstructions. And here again, you can see the conventional on the left, but on the right side, if we go to low virtual mono E, you can nicely see this delayed enhancement in the septum right here. And this is pretty clear. So this is mid-wall delayed enhancement, and we correlated this with an MRI scan a little while earlier before implantation. You can actually see that there is delayed enhancement right here in the septum that correlates very nicely in terms of mid-wall enhancement with a CT scan that I showed you in the previous slide. So also I mentioned incidental findings. This spectral CT is a especially powerful tool for definitive characterization of incidental findings. And here are a couple of examples. So this is a patient who came in with a trauma. So this is a non-cardiac triggered CT. And this patient has, as you can see, a venous aneurysm of a coronary vein. And also a dense pericardial effusion. So the question is there some kind of trauma to this vein? Is there a bleed in the pericardium? And we'll have to see by using the spectral information if we can shed some light on this. So obviously iodine density would be a good tool to use here. And you can see there are some artifacts, and that's because this is a trauma patient with the arms placed to the side of the body instead of elevated as we would normally scan them for cardiac purposes. But if we zoom in a little bit, we can see here that this pericardial effusion has a density of about 44 Hounsfield units, which could fit with some blood. But if we use the iodine density, there's a zero concentration of iodine. So we concluded from this that the likelihood of a bleed is very low. This is another reconstruction of the same patient in a different orientation. So again, the pericardial effusion has a Hounsfield unit value of about 44, and the iodine density images display a concentration of 0 milligrams per milliliter. So we can confidently rule out any trauma due to this vein due to the spectral reconstructions. TAVI imaging is something we do a lot of in Utrecht. So we get these nice images of the aorta. You can see that this patient has a heavily calcified aortic valve that opens only very marginally. So a good TAVI candidate. But in these patients that tend to be older, we often have incidental findings. And here's an example of such an incidental finding. So this patient had this hypodensity in the right liver lobe, which is better visible using low mono E images. And this turned out to be a colon carcinoma metastasis. And as you can see, you can pick this up on the conventional images. You see it better on the low mono E's, but that is not the point in this patient, because the point is we were actually able to identify several additional mets in the liver by using the low mono E. So here's another one in the right liver lobe, which is also visible vaguely on the conventional images right here. But this other metastasis in segment 1 of the liver is not visible at all on the conventional images. And this is, again, a very powerful tool. This is another patient also coming for TAVI workup, where we see this very faint blush here in the left liver lobe, which becomes much better visible when we use low mono E. And what we see here is that this patient had a hepatocellular carcinoma, which heavily enhances on the arterial phase, and this should alert the reading physician that this is a finding that needs additional evaluation. Finally, I want to finish off with a couple of words about radiation dose. This is something I get a lot of questions about, because basically what we do is we scan with 120 or 140 kVp as the default scan mode. But by using iterative reconstruction, we can actually lower the MAS value and thereby remain at a similar or even lower dose compared to non-spectral CT scanning. And we looked at our numbers in Utrecht in this paper that was published in 2019, where we evaluated over 10,000 examinations acquired on 2 scanners, one spectral, one not. And you can actually see by looking at the orange bars that most of the time the scans are actually of lower dose. So I want to conclude by saying that always-on spectral CT is a highly useful tool in cardiovascular CT. It provides more certainty and unmasks unexpected and unrequested relevant findings with certainty. There are more options and flexibility with regard to imaging protocols because of the new features in the system, such as the 8-centimeter detector, fast table movement, and advanced motion correction. I told you the system facilitates lower dose contrast medium protocols because of the ability to reconstruct very high contrast to noise, low monoenergetic images that boost iodine contrast. And finally, we can also use lower radiation dose because we can skip non-enhanced phases, and we can actually reduce the radiation dose by also going to very low MAS values. With that, I'd like to thank you for your attention, and I open the floor for questions.